All right, welcome to Three Plastic Surgeons and a Microphone. Unfortunately, Sal isn't with us for this one, but we do have Dr. Sam Jejurikar out of Dallas, Texas. Instagram handle is
At Sam
at,
Jejurikar.
thank you, at Sam Jejurikar. I am Sam Rhee out of Paramus. I've only said it like 500 times. But it's been a while. I'm Sam Rhee out of Paramus, New Jersey. My Instagram handle is at Bergen Cosmetic. And Sal is San Diego plastic surgeon. He's out of La Jolla, California, and he'll be joining us for other episodes. But today we have a very special episode, which we will be talking about some of the recent changes in BBL or gluteal fat transfer surgery that have occurred in Florida. And Sam will be taking us through some of those changes and what's occurring. But first, let's go through our disclaimer.
To all our listeners, this show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified providers with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something you see in this show. And before I hand it back to you, Sam, I think the real reason Dr. Pacella doesn't want to be with us is he doesn't really love this operation like you and I do. So with that, any thoughts on anything before we sort of get into the meat of the topic?
Absolutely. I'm so glad that we're talking about this. There's been a lot of stuff in the media and out in public, and I feel like if anyone is going to get ahead of this and sort of provide the best information about what's been going on, it's going to be us as plastic surgeons. And so before anyone hears or sees anything that's sensationalistic or not true, actually, I'm really glad that we're sort of breaking down this topic for people.
Perfect. So let's get into it. So let me get my screen loaded up here, and we'll just confirm that everyone can see this okay. Can you see this all right, Dr. Rhee?
It looks great.
Perfect. So just to get started, BBLs have had a long, complicated history. Prior to about 2016, 2017, plastic surgeons largely operated in a state of blissful ignorance where we didn't realize how deadly this operation was. 2016 studies came out of Central America and Mexico. 2017 in the U.S., we began to realize that the death rate was in the vicinity of approximately 1 in 4,000. At least that's what it was being estimated as. Throughout the world, there was talk of actually banning the procedure. In the U.S., as well as most countries in the world, instead, plastic surgeons came up with some very salient recommendations. And the big task force was the Multi-Society Gluteal Fat Grafting Task Force, which was made up of, by the time it was said and done, about 50 plastic surgeons. The recommendations were you need to inject superficially whenever you do fat injections. The reason for this was people were dying because of deep injections or even injections into the muscle itself that would cause the fat to go through the muscle. It turns out the back wall of the gluteus maximus muscle is very thin. The front wall is very, very thick and an effective barrier. But if you inject it in the muscle, the fat could actually come down through the muscle, put some pressure on some very thin-walled, deep veins, cause a hole in those veins. It would get sucked up into your circulation, travel to the lungs, and cause what's known as a fatal pulmonary fat embolism and sudden death. So the fat grafting task force said, hey, don't do that. Inject in front of the muscle. Stay superficial where you have that nice barrier so patients won't have death. Use blunt cannulas. And big cannulas that are at least 4.1 millimeters or greater. Don't use a lot of pressure when you do the injections, and don't angle your hand downwards. And it seemed to help. I don't know about you, Dr. Rhee, but in my community, I hadn't heard about anybody dying. Same for you?
Yeah, I think the biggest issue was either overseas in the Caribbean or in Florida, where there were a number of high volume surgical centers that were not very well regulated or overseen that really resulted in a significant patient morbidity and mortality. And that's what raised the alarm with this.
Yeah, and in fact, when you break down the first couple of years after the recommendations came out, particularly 2018, 2019, there weren't a lot of deaths in Florida. But then in the last year, basically in 2020, or I'm sorry, 2021, there were 8 deaths in South Florida, and this caused a major ruckus. South Florida, just like you alluded to, is a very different plastic surgery market than other places in the country. People throughout the country are flying there to get their surgeries. They basically meet their surgeons right beforehand. There's in these clinics where they basically specialize in doing Brazilian butt lifts. 10 or 15 of them are being done in a day, probably several happening simultaneously. And so the Florida Medical Board put in an emergency action. They basically said, okay, enough's enough. We're not going to limit the number of Brazilian butt lifts that can be performed a day to only 3. The rationale is that it limits fatigue. It ensures the same surgeon is actually doing the surgery. And I think, if you think about it logically, if a Brazilian butt lift takes the average surgeon, say 3 hours, it makes sense. That's 9 hours in a day. That would limit, the fatigue, and it's hard to envision how you could do a lot more than that. The other thing they said was you have to do ultrasound guidance during the injection of the fat to ensure that superficial injections are actually being performed. And so that's the emergency action that went into place on June 3rd. There's been a group of 7 plastic surgeons that have actually challenged this. They basically argued that plastic surgeons aren't trained in the use of ultrasound. And they say that because other procedures aren't being exempted, this argument about physician fatigue is sort of nonsensical, meaning a surgeon can perform 10 tummy tucks in a day. Why are they only limited to 3 BBLs? So what do you think about that, Sam? I mean, is ultrasound something that you feel like you have no experience with?
Well, no, that's not true. This is an interesting. So basically, the Florida Medical Board are responding to these issues, and whether or not this is correct or not, Florida has always had sort of a unique situation when it's come to medical care and plastic surgery. Even before this, they have regulations that we in other states do not have. For example, they limit the amount of liposuction that you can perform at the same time as an adjunct procedure, such as a tummy tuck, up to about 1 liter, for example, if you're doing it in an office-based environment. And again, a lot of what they're doing is based on these high volume plastic surgery clinics or cosmetic surgery clinics that are occurring in Florida. And I am very glad we're talking about this, because I really would like to know more about the reasoning behind this and about the plastic surgeons who are also challenging this in Florida. This only came out a couple of weeks ago. So what's your take on this right now, Sam?
So it's just personal speculation. I don't have any data to back this up, but I mean, the business model in South Florida is one of low cost and high volume. People fly there from across the United States because they know they can get surgery for a substantially discounted rate than what they might be able to get in my office or in your office or in most plastic surgeons' offices. You sort of eliminate that personal care, right? Your initial consultations oftentimes are done virtually or via email. But the way that these businesses will survive economically is by doing a large number. If you limit the number of procedures that can be done in a day to 3, you potentially harm the viability of some of these practices that are out there. In terms of the use of ultrasound, I mean, I believe most plastic surgeons who are of our generation or younger have extensive experience with ultrasound. I mean, I did, much like you, extensive general surgery training before plastic surgery, where we used ultrasounds, and we're very comfortable looking at soft tissue. And so I don't think that's really true personally. I think the physician fatigue argument, yeah, I mean, I do think that if you look at your performance near the end of the week, during multiple long operations, multiple long days, I mean, there is a tendency to get tired, to be tired. I don't know if that's actually what the Florida Medical Board is going after, or if they're just trying to make sure that surgeons are actually doing the procedure, though, to be honest with you. Because one of the things that I've heard from a plastic surgeon that's there is they're trying to get to the point where they actually have plastic surgeons be videotaped doing the procedure with a timestamp to prove that they're actually the ones doing the operation. So that's kind of my thought.
They actually have instituted that in Korea because there was such a high number of ghost surgeons where surgeons were ostensibly doing the procedure, but they were actually not. So that there is a precedent for that actually occurring in other countries.
So I want to kind of focus on the ultrasound aspect of things. So over the last few years, since 2017, 2018, there have been multiple techniques described with the use of ultrasound to do Brazilian butt lifts. And all of these seem to be great in theory and very difficult in practice, because they were two surgeon techniques where basically one surgeon was injecting fat and moving their cannula back and forth while they were doing the procedure, and the other surgeon was trying to mimic the motions of the other surgeon and go back and forth and follow the cannula at all times. And the problem with that is it's very easy to lose track of where the cannula is if you're going back and forth, even if you're controlling, the ultrasound with your other hand. But with two different people, there's no way to know exactly where they're going to go. And so most of these never really took off. They were thought to be slow, inefficient, not that reliable. But recently, a technique has been described by doctors Pat Pasmino and Dr. Dan Del Vecchio. And they've really sort of pioneered a new way of doing ultrasound-guided BBLs, which is very efficient, very reproducible, and very safe. It changes the way that we do the injections in the sense that we are not moving our cannula back and forth while we are doing the injections, but it allows us to put it in a safe plane, and then it allows us to redistribute the fat afterwards. Have you seen any of these presentations, Dr. Rhee?
No, not yet.
Well, I have adopted much of their technique, and I've been doing it now for the last few months. And so the first thing is I want to, this is from a case I did this past week. Okay, and I want to here sort of explain to you what I did. I bought an ultrasound probe. It's a few $1,000 a month, and a yearly subscription of a few $100s. So it's not that expensive. It's wireless with Bluetooth technology, so it basically links to an iPad or my iPhone. We put it in a sterile glove, and then we use ultrasound gel, and we get great quality images. So what are we looking at? I think, this is the key. So when we are doing a gluteal fat grafting case, okay, what we're looking at is we're trying to make sure we stay away from the muscle. So on the bottom, you see this striations on the bottom. Can you see that, Sam? That's the gluteus maximus muscle.
Yes.
Right here, okay? So what we see here, this very radio opaque or bright line, like straight line right here, is my injection cannula. So we know that if this is the edge of the gluteus maximus muscle, right here, we're staying above that. Well, one of the things that Drs. Del Vecchio and Pasmino have really kind of hit home, and it makes a ton of sense, is that in the subcutaneous tissue, you have, or a subcutaneous tissue is another word for fat. You have what's called an investing fascia called scarpus fascia. And for our listeners, that's what sort of divides the superficial fat from the deeper fat. Again, deeper fat is still in a safe anatomic plane because it's above the muscle. But if you can inject your fat in a plane that is below this scarpus fascia, okay, you'll notice here now this fat is starting to blow up. Can you see the fat going in there?
Yep.
The fat is actually pushing the muscle down, and conversely, it's bringing your skin out. So what does that look like on the skin? So what I'll do is I'll stick my cannula. I don't know. The skin in the fatty layer. I'll confirm using the ultrasound. I'll use the ultrasound to confirm the safe line, and then I'm moving my hand at all. This is not very exciting of a watch. But if you look, okay, we'll start on this image on the right first. You can start to see the skin is slowly starting to pop up. Do you see that fat starting to come up here? Your fat is slowly coming up. You look on the left right here, you slowly start to see everything expand. So literally what I'm doing is putting in my probe, verifying that the cannula is in the right dip, verifying that the injections are starting off in the right plane, and then in just 3 or 4 spots, in the entire buttock, I'll put in a few hundred cc's in each spot. So it's actually not that much slower to do it because you're actually blowing with all of this fat. It actually sort of gets localized in various compartments within the fatty tissue, and then you just spread it out when all's said and done. So what you're actually doing is you put all the fat in, and I'm demonstrating the hip, buttock in this area right here, and then what we'll do is we'll see our results. And so what I'm finding is I'm using the same amount of fat as I always have in patients. So in this patient here on the left, it's her preoperative view. It actually put some fat in the hips already from the front, so she already has a fairly nice curve. But you can kind of see how there's not a lot of projection. It's pretty flat. Here I did an on the right, and this is from this past week. I did an ultrasound guided BBL, and you can see the amount of projection that she has. So I'll put the fat in just in 3 or 4. So you see how much that butt's popping there, Sam? Can you see that?
Yep.
How much that comes out?
Yes.
And you just spread it around, all said and done. Voila. What we have here is we have a way of doing things, which is easy. Probably 30 minutes to learn how to do this at the most. It is reproducible, and it's safe. We know with complete 100% certainty that all of our fat is in the fatty layer, and it's not in the muscles. They're not going to die of fat embolism. Here's another case, maybe. So another case from this week. Again, this patient is before pretty flat. She's one central projection. Again, we used ultrasound guidance, and you see that there is this nice projection again. And we know that this is this. I think that even if this only becomes a rule in Florida and no other state adopts this, I think you're going to see more widespread adoption of this technique in plastic surgery over the ensuing months and years to come. I don't see any downside to it, really, other than the cost of an ultrasound and a little bit of extra time. But in my hands, at least over the last few months, I haven't seen any compromise in results, and it's an added safety measure so that I can look and be 100% sure that my cannula is in the safe place. And what I will say is that, don't allow 100% confident I knew which plane I was injecting in. And now what I'm seeing is that, can you see me okay? Is everything?
Yeah. Mm-hmm.
You there?
Yes.
Okay,
go ahead.
What I'm seeing is probably in every case, or at least every other case, there's going to be a period of time where I'm thinking I'm getting in the deep fatty layer, and I check with the ultrasound, and it actually is in the very superficial muscle. It's actually kind of scary about how we can end up in the muscle and actually think we're in the fatty layer. So I really like this added safety measure.
I think that it's super interesting, Sam. Thanks for sharing that. I am not sure, like you said, this is something that's extremely new in terms of, I don't think anyone a year ago or 2 years ago would have thought that this was going to be something that was either mandated in Florida or something that would be considered to be routine. And I think that there is certainly a lot here to unpack in terms of changing surgeons' techniques. I know that you and I have both done thousands of BBLs in the past, safely and well. Added safety measures are always welcome and should definitely be looked at. I always worry a little bit about regulation in terms of mandatory anything for surgeons. Unfortunately, I feel like the ones who generally force our hands are the inexperienced surgeons, or the surgeons that don't really sort of do well with particular techniques. But in this case, this is really interesting. It looks like the results are amazing. I'm really interested to see, I'm always a little bit more of a conservative guy. I like to see in your hands, obviously, Sam, this is a really superior, but you're an exceptional surgeon, Sam. Let's face it. You're not just an average surgeon. You're an exceptional surgeon. And how about when this gets into everyone else's hands, in my hands, and other people's hands? What are those results going to be like? What are the long-term results going to be like? I have a feeling, Sam, no matter what technique you use, you're going to get an amazing result. You are extremely experienced and you're really good. I would like to see multiple systems, multiple surgeons, more results. I feel like everyone has their own personal preference in terms of what they do, and I know that. When one of the biggest things I've learned talking to you and Sam or Sal is that we all have similar goals and similar outcomes for many things that we do, but we also have little tweaks about how we do certain things. And I feel like this is really exciting. I certainly am going to explore this and find out more. I know the two surgeons that you've mentioned who have sort of pioneered some of this work is they have been on the forefront of fat grafting for a long time. I will say that this is definitely different in terms of the technique. Like, I am so used to dynamically injecting fat, the whole concept of static fat injection. This is the first time I've heard of it or seen it presented, and it's very exciting. But like you said, it does take a little bit of learning, and maybe not all surgeons can learn it in 30 minutes like you can, just because they're not as quick as you. So I'm really excited. Can't wait to see more. If this is something that proves to be helpful in Florida as well as everywhere else, we very may well see this become widespread. So it's great that you're on the forefront of it, that you're examining it and incorporating it, and I look forward to hopefully me and other people looking at it and doing the same.
Yeah, maybe I'm exaggerating when I say it takes 20 or 30 minutes to learn how to do the technique. I do have a baseline comfort with ultrasound, as I know you do as well. But it is as you allude to, it's a very different way for doing fat injection. One of the ways that we have always been taught is that you need to be moving your hand while you inject fat. And the reason we do that, though, is to avoid the major reason we do that is to avoid trauma to blood vessels. So with ultrasound visualization, the stationary injection ensures that we're avoiding those major blood vessels that actually can cause an issue. So from a safety aspect, if you have that confirmation, it's actually a very, very safe way to do things. The thing that's always a little concerning the first time you do it is when you're done with these injections, and I should have put some pictures of this up. The butt looks kind of lumpy. It looks like you've got 4 distinct heads of broccoli or cauliflower. And so it takes a couple minutes to spread it out afterwards to make it look even. But if you are good about injecting in that plane, deep discarpus fascia, but superficial to the anterior gluteal fascia, meaning in the deep fatty layer, it's very easy to spread it around. It looks good very quickly.
I know our national meeting's coming up in October, and I'm sure we're going to see a lot more of this as well in there, probably.
Yeah, absolutely. Absolutely.
Are you planning on presenting?
I'm not. So the technique I presented right here was presented at the Aesthetic Society and at Baker Gordon by Del Vecchio.
Okay.
There was and the Aesthetic Society has really pushed this a lot. Again, this is a slight modification of the technique of Pat Pasmino and Dan Del Vecchio. This is their technique, their description, so they're the ones that are presenting it. I'm an early adopter because it's a really good way of doing it.
That's awesome.
Wonderful. Well, I think that's all we got for today. Hopefully our viewers got something out of this. And thanks again. I'll see you soon, Sam.
Thank you so much, Sam. I really appreciate it.
Take care.